Okay, now it's your turn. I hope you feel inspired. Those of you who are working in this sector by Terry's remarks, Barbara's remarks, Kyle's remarks, you have huge opportunities ahead of you in terms of building out the kind of systems that we need and the architecture that Terry just talked about, which I find fascinating. I need to learn more about it. So as people line up at the microphone, welcome your questions. I just wanted to start off really quickly noting what the new quality measures are that are required under the Impact Act that just passed, I think, on September 17th before Congress left town. Just so everybody knows, the new quality measures that all post-acute care providers will be required to report are functional status, cognitive function, special services treatments and interventions such as need for ventilator use, dialysis, chemotherapy, central line placement, and total parenteral nutrition, medical conditions and comorbidities such as diabetes, congestive heart failure, and pressure ulcers, impairments such as incontinence and an impaired ability to hear, see, or swallow, and other categories deemed necessary and appropriate by the Secretary. So I just let you know that that's actually read from the legislative language so that you can see that we're moving into a new era of really looking at function and really looking at the kinds of capabilities that we need across a much broader set of service providers than we have in the past. And it also will be sort of correlated with claims data to look at utilization. So we're entering into an era of much greater accountability, and I personally think that's good. I'd love for Barbara and others to comment a little bit on that, and then we'll go to the mic.
Thanks, Ann. I'd love to. I'd like to just underscore how that range of quality metrics that Ann just read out of the legislation are all factors you're already collecting. They are the basic factors that you monitor when you're taking care of a patient, and either they don't apply because the patient has no cognitive impairment, or they do matter, the comorbidities, and you want it in a standard exchangeable area. So just so nobody goes into panic, they're all just things straight out of your records.
Okay.
Peter Bowling from Richmond, Virginia. So this is really for for Terry and Kyle. Both of you guys work for integrated delivery systems. I know things are all peaceable in Newport News and Boston. There's a little conflict. And I really like the Lego model. So I have a 4.5-year-old at home. We do a lot of Lego work. It's just about right size for me. My question is about the politics. So one of the patients I've been managing today, long-term enrollee in our house calls program, actually in a managed care plan with which I'm participating, was taken to a local community hospital, then admitted to a nursing home where I am his doctor, and now on a really an emergent basis, back in an ambulance where the EMTs, instead of taking him where I work, took him to a community hospital where they read our electronic health record remotely, note my role as PCP, and then assign the patient to doctors who are part of that health system for follow-up. Which is great in the sense that they're looking for some continuity of information, but sort of stealing the patient away from the doctors that have ordinarily taken care of that person. So how do you reckon with that? You know, what's going to drive change in that? Because I'm actually all in favor of exchanging information, but how do you keep that behavior, which seems sort of one of our lesser favorable attributes as humans, from interfering with the process of care?
Well, Peter, I'm sorry to hear that things aren't as peaceful where you are as they are in Boston. That doesn't happen ever in Boston. And, you know, I think part of it is how do we empower the individual? And, you know, where can they step up and say, hey, this is my doc, this is where I want to go, this is how I want to be there. So I think part of it is making sure that the individual has the information and really feels that they have a role in determining where their care gets placed. Other than that, I think what's going to happen is there are going to be sort of basic rules of the road that get worked out between ACOs and shared savings plans. And yeah, it's going to be ugly. I don't want to be in those meetings. You know, you're talking about business and volume. And until the way we fundamentally pay for care, then that's going to continue. There'll be competition. So now Kyle may have a much more optimistic view than
No, I was sitting there thinking, well, how do I answer that? And I'm going to jump on that's exactly where I went to, is the the empowering the individual. And I actually can use Richmond. So as you well know, we've got 3 PACE programs, and we don't really do a really good job there of making the patient informed or the participant informed or accountable too. So there's an accountability on behalf of the patient in that managed care model that if you go out of network, you have to pay out of pocket versus being all part of all-inclusive care. So I think there's ways to get around it. It has to do with education, I think, in particularly the PACE program. But that's an example I can actually bring from Richmond that we're having difficulty with trying to get that continuity established, because you know the impact of that, right? So real life world for you and I in Richmond with Riverside's 3 PACE programs, and I would have to say it's going to have to be with alignment and financial alignment and policy change.
Yeah, and actually, as I'm thinking about it, if it's the EMTs that are the problem, well, the EMTs are also part of this exchange. You can imagine an EMT coming up and getting a feed, a download of all the information they need to safely transport the patient off to the hospital. That also includes in that download the hospital preference, the PCP, the numbers to call. Do not take them X, Y, and Z. So I think we're going to have some electronic backups to the care trajectory that you hope for.
I just wanted to add to that in that Medicaring for our life, part of that community board, part of that community organization was to bring EMS to the table. And when I've worked with trying to put care coordination networks together between hospital and skilled care, EMS played a tremendously valuable role, and oftentimes we leave them outside the discussion and out of the table. But they can be very, very, at a grassroots level. I'm not talking about policy and that type of thing, but just working locally, bringing EMS to the table and working together, you can have some impact on that.
In fact, there are many examples, several growing numbers of examples on the West Coast where the EMTs are tied in, and they're actually functioning in some respects like the case manager, because they know those high return cases, and they know the home, they know where that patient needs to go, and they communicate with the hospital as opposed to just leaving it up to the local community. But the home health agencies also have those little magnets that people put on the refrigerators. My doctor, my hospital.
If you all wouldn't mind following us out, anybody who would like to ask further questions, we talked too long, so we have to move to the next panel, but we're out there for anybody who would like to ask us questions. Thanks so much.
You didn't. I did.